Thank you for joining this training on the Coma Recovery Scale Revised for Accelerated Standardized Testing. This training will guide you through the background and clinical need for CRSR-FAST, how it compares to the full-length CRS-R, and why it's a valuable tool for clinicians working in fast-paced clinical environments. We will also review general guidelines for administering and scoring the CRSR-FAST, including protocols for arousal facilitation and methods for assessing key signs of consciousness, such as command following and automatic motor behaviors. To appreciate the development of the CRSR-FAST, it is essential to first understand the foundation provided by the Coma Recovery Scale Revised, or CRS-R. The CRS-R is a standardized neurobehavioral assessment tool designed to detect conscious awareness in patients with severe brain injury, particularly those who are unable to reliably follow commands, communicate, or use objects appropriately. Prior to the CRS-R, clinicians lacked standardized measures for evaluating patients with disorders of consciousness. This gap made it difficult to assess individuals who could not participate in conventional cognitive testing. Moreover, commonly used assessments were not sensitive enough to detect the subtle behavioral changes that often occur during recovery. This limitation could result in missed opportunities for accurate diagnosis and prognosis. Identifying conscious awareness with precision is critical for establishing diagnosis, guiding treatment planning, predicting outcomes, and facilitating communication with families. The CRS-R addresses these needs through a structured format consisting of 23 items across 6 subscales. These subscales are hierarchically organized to reflect increasing levels of behavioral complexity. The assessment typically requires 15 to 30 minutes to complete, depending on the patient's level of responsiveness. Due to the time constraints clinicians often face, combined with the limited tolerance some patients have for extended periods off sedation, administering the full CRS-R in the intensive care unit can be challenging. This clinical reality highlighted the need for a more efficient, standardized assessment tool to evaluate conscious awareness in patients with severe brain injury. In response, the Coma Recovery Scale Revised for Accelerated Standardized Testing, or CRSR-FAST, was developed. The CRSR-FAST is a streamlined version of the full Coma Recovery Scale Revised, designed to support rapid assessment of conscious awareness in fast-paced clinical settings. The full CRS-R includes 23 items across 6 subscales: auditory, visual, motor, oromotor, communication, and arousal, and is depicted on the left side of the screen. When administering the CRS-R, clinicians are expected to proceed through each subscale until a scorable response is observed. CRSR-FAST is an abbreviated version of the CRS-R that focuses on 5 core behavioral observations, allowing clinicians to capture meaningful indicators of consciousness while maintaining diagnostic integrity in fast-paced environments. The 5 core behaviors selected for CRSR-FAST, which are shown in the box on the right, were chosen because they are among the earliest indicators of conscious awareness to emerge during recovery. This abbreviated format allows clinicians to efficiently evaluate key signs of consciousness while preserving the diagnostic integrity of the original scale. This slide outlines the core characteristics of the CRS-R and CRSR-FAST, highlighting both their similarities and distinctions. Both assessments are designed for the same patient population: individuals experiencing coma, vegetative state, or unresponsive wakefulness syndrome, and the minimally conscious state. The full-length CRS-R is intended to evaluate the level of consciousness across the entire continuum, from coma through emergence from the minimally conscious state. In contrast, the primary purpose of the CRSR-FAST is to determine the presence or absence of conscious awareness. The CRS-R consists of 6 subscales: auditory, visual, motor, oromotor, verbal function, communication, and arousal. Each subscale contains hierarchically arranged items, and the maximum score varies across subscales. Unlike the CRS-R, the CRSR-FAST does not include individual subscales. Instead, it focuses on 5 core behaviors: command following, visual fixation or pursuit, automatic motor response, localization to noxious stimulation, and intelligible expression. These behaviors are scored as either present or absent and are administered sequentially until a scorable response is observed. Finally, the administration time differs significantly between the 2 tools. The CRS-R may take up to 30 minutes to complete, depending on the patient's responsiveness, whereas the CRS-R-FAST can typically be administered in approximately 6 minutes. The CRS-R-FAST provides a time-efficient alternative to the full-length CRS-R, enabling clinicians to assess conscious awareness in ICU settings where extended evaluations may not be feasible. Its abbreviated format, requiring approximately 1/3 of the time required for the CRS-R, facilitates administration during sedation weaning and supports serial assessments, which are critical for capturing fluctuations in consciousness. Timely and accurate detection of conscious awareness informs diagnosis, prognosis, treatment planning, and communication with families. The following slides will outline general guidelines for administering and scoring the CRS-R-FAST. Later in the presentation, we will review how to assess specific indicators of consciousness, such as command following and localization to noxious stimulation. To accurately administer the CRS-R-FAST, it's important to assemble a basic toolkit with the appropriate materials. Your toolkit should include a copy of the CRS-R-FAST manual, a handheld mirror for assessing visual fixation and pursuit, and 2 common objects, such as a ball and a cup, for evaluating command following and functional object use. You may also consider including other familiar items, such as a hairbrush, spoon, or toothbrush, to support object-based tasks. Before administering the CRS-R-FAST, examiners should be familiar with the administration guidelines outlined in the manual. It is also important to review the patient's medical record or consult with the clinical team to identify any confounding factors that may influence the assessment. When possible, the examiner should administer the CRS-R-FAST when sedation has been lifted. However, if it is not possible to wean or lift sedation, the examiner may still perform the assessment and test completion codes must be applied accordingly. The examiner should document the medication and dose on the case report form. The examination can also be performed in patients who are intubated, and this should also be documented on the case report form. However, the CRS-R-FAST should not be performed if paralytic agents have been administered. Prior to administering items on the CRS-R-FAST, the examiner should observe the patient for 1 minute and record any instances of spontaneous behaviors before intervening. If the patient's eyes are closed or if there are other signs of under-arousal, the examiner should administer the arousal facilitation protocol. This slide presents the Arousal Facilitation Protocol, which is designed to help patients maintain arousal or wakefulness throughout neurobehavioral assessments to achieve the most accurate results. The protocol should be initiated whenever the patient's eyes close or when there is no response to verbal or tactile stimulation. To perform the protocol, deep pressure stimulation is applied unilaterally to the patient's cheek, sternocleidomastoid, and trapezius muscle. The examiner firmly grasps the base of the targeted muscle between their thumb and forefinger. While maintaining firm pressure, the muscle is rolled back and forth between the fingertips 3 to 4 times. Before administering deep pressure, always confirm the absence of intravenous lines, local injuries, or systemic complications in the targeted area. After completing stimulation on one side, repeat the procedure on the contralateral side as needed. Note that the item localization to noxious stimulation may also be scored if the patient uses their non-stimulated limb to make contact with the examiner's hand during administration of the arousal facilitation protocol. Before initiating the CRS-R-FAST, the examiner should document key observations on the record form, including the patient's resting posture and any spontaneous behaviors. This section should also include any psychoactive medications or paralytics the patient is receiving at the time of the assessment. Additionally, the examiner must identify and note any potential confounding factors or conditions that could alter, mask, or mimic the patient's true level of consciousness. Failure to account for these variables may lead to misinterpretation of the patient's neurological status. Here is an example of how to document resting posture, spontaneous behaviors, psychoactive medications, and potential confounding factors on the CRS-R-FAST record form. To account for confounding factors, the examiner should check for recent or ongoing use of sedatives, anesthetics, or psychoactive drugs, including medications used during surgery to induce unconsciousness. Patients under the influence of these agents may not respond to stimuli, which can mimic a disorder of consciousness. Consider events within the 24 hours leading up to the examination, such as medical procedures performed under general anesthesia. Under-responsiveness may be due to lingering effects of medication rather than a true disorder of consciousness. Note any clinical or EEG evidence of ongoing or recent seizures. Seizures can cause unresponsiveness or abnormal movements, potentially obscuring accurate assessment. Consider physical barriers, such as the placement of a breathing tube with mechanical ventilation. This may physically prevent speech or voluntary movement, making it difficult to assess purposeful responses. Assess for high fever, as elevated body temperature can cause delirium, confusion, or reduced responsiveness, which may not reflect the patient's baseline neurological function. Evaluate for other reversible factors, such as metabolic disturbances or severe fatigue, which may cause the patient to appear unresponsive, but are not due to a structural brain disorder. This is not an all-inclusive list of confounding factors, but it highlights those that are most common. If additional confounding factors are present, the examiner should document them in the note section. While administering the CRS-R-FAST, the examiner should adhere to all instructions on the case report form. When the examiner provides the patient with an item or prompt, they should wait 10 seconds to observe a clearly discernible scorable response. The examiner should use the 9 out of 10 rule of thumb, meaning that if there are 10 examiners observing the same behavior, then at least 9 should agree that it is clearly discernible in order to score it as such. Note that there is no specific test procedure to assess for automatic motor behavior, as this core behavior is only scored when the patient demonstrates spontaneous movements during the examination period. The examiner should always administer the command following items regardless of whether other signs of consciousness are observed at any other time during the exam. If the patient closes their eyes during the examination, the examiner should administer the arousal facilitation protocol. The examiner can discontinue administration of the CRS-R-FAST if the patient demonstrates reproducible command following, which is a behavioral sign of consciousness. If command following is absent, the examiner should continue the assessment until the first behavioral sign of consciousness is detected. When the first behavioral sign of consciousness is detected, the assessment can be discontinued. The examiner can re-administer the command following or the intelligible speech items using written instructions if they suspect the patient has a peripheral or central auditory impairment. During the assessment, the examiner may write notes or more detailed information regarding the observations or concerns that might have influenced scoring of any of the items in this space on the record form. If the examiner administers the arousal facilitation protocol during the examination, they should also use this space to record the number of times the protocol was administered. After administering the CRS-R-FAST, the examiner must determine whether the results gathered are truly valid. This is where test completion codes, or TCCs, become essential. TCCs are used to indicate whether an assessment was valid or not. These codes are designed to help the examiner document any factors that might have influenced the assessment so that anyone reviewing the results later can understand the context and reliability of the findings. TCCs also allow the examiner to explain why a test might not have been completed as intended, or why the results might not fully reflect the patient's true abilities. The record form provides both checkboxes and a free text area for the examiner to note any circumstances that could have affected the assessment. At the end of the assessment, the examiner should select the test completion code that best reflects the validity of the test score. If the assessment was valid and there were no confounding factors, they should use the first completion code of 1. However, if the examiner suspects that the assessment wasn't valid, they should choose the appropriate TCC and provide any additional details in the free text space. By carefully documenting these circumstances and selecting the right test completion code, the examiner helps ensure that the assessment results are transparent and meaningful. This process not only supports accurate clinical decision-making, but also helps anyone reviewing the results understand exactly what happened during the assessment. A test may be attempted but not completed, or it may not be attempted at all for various reasons. This slide summarizes some of the most commonly documented test completion codes. For instance, a patient with impaired sensory function, such as numbness or cortical blindness, may be unable to respond to certain test items. In these situations, the examiner should use an appropriate TCC to document the limitation. Physical impairments are another frequent reason for incomplete assessments. Conditions such as hemiplegia, fractures, burns, splints, or spinal cord injuries may prevent a patient from fully participating in the evaluation. Language barriers can also significantly affect the validity of the assessment. These barriers may result from primary language differences or conditions such as aphasia, which impact expressive or receptive language abilities. It is especially important to recognize that diagnosing aphasia is particularly challenging in patients with disorders of consciousness. The CRSR-FAST manual includes a record form for documentation of the patient's performance. The record form has 3 parts. First, there is a section that contains the 5 core signs of consciousness: reproducible command following, visual fixation and pursuit, automatic motor response, localization to noxious stimulation, and intelligible expression. These are the primary behaviors that are assessed on the CRSR-FAST. On the right side of the record form, there is a section for recording trial-level responses for each behavior. A correct response for a trial is represented by a plus sign. An incorrect response for a trial is represented by a dash, and a non-response for a trial is represented by a 0. Finally, in the column to the left of the record form, there is a section for documenting the overall presence or absence of each of the core behaviors. The presence or absence of a behavior should be determined using the scoring criteria for each behavior, which are summarized in the instructions for item administration on pages 4 to 5 of the manual. If a behavior is present based on the scoring criteria, the behavior is scored as a 1 in the left column, whereas if a behavior is absent based on the scoring criteria, the behavior is scored as a 0 in the left column scoring criteria. The behavior is scored as a 0 in the left column. It is important to note that unlike the full-length CRSR, the CRSR-FAST yields a dichotomous rating of presence or absence of consciousness as opposed to a total score. Once a core sign of consciousness is scored as present, the examiner may discontinue the assessment. However, in some circumstances, the examiner may elect to administer all items to obtain additional diagnostic and clinical information regarding the patient's level of function. Please note that although some of the behavioral features that differentiate the minimally conscious state plus from the minimally conscious state minus are displayed on the record form, the CRSR-FAST does not include all the distinguishing features. Reproducible command following is the first core sign of consciousness to be evaluated when administering the CRSR-FAST. This is a key item on the CRSR-FAST and should always be administered even if other spontaneous signs of consciousness are observed. To assess reproducible command following, the examiner should refer to the administration instructions summarized on page 4 of the manual. The examiner will select at least 2 different eye movement, limb movement, oral movement, or vocalization commands to administer. The same command should be administered for 4 trials. In other words, the examiner should complete 4 trials for each of the selected commands to obtain a total of 8 scorable responses. The examiner should record the patient's response to each trial. For example, let's say the examiner first selects a limb movement command and instructs the patient to take the ball. The patient correctly responds to the prompt on the first 2 trials, then does not respond on the 3rd trial, and then correctly responds to the 4th trial. Therefore, based on the scoring criteria, the examiner could score reproducible command following as present because the patient provided at least 3 clearly discernible and accurate responses over the 4 trials of the limb movement command. In this case, the examiner would mark the left-hand column with a 1 to indicate that the behavior is present. The presence of reproducible command following suggests that this patient is conscious. Therefore, the examiner can discontinue the remainder of the assessment. However, if the patient provides an incorrect response to 2 or more trials of the limb movement command, then the examiner must select a new command and administer another 4 trials. Let's say the examiner selects an eye movement command and instructs the patient to look up at the ceiling. If the patient provides at least 3 accurate responses to the eye movement command, then the patient meets the criteria for reproducible command following. The behavior can be marked as present with a 1 in the left-hand column, and the assessment can be discontinued. However, if the patient also misses 2 or more trials of the eye movement command, then the examiner should mark a 0 in the left-hand column to indicate that reproducible command following is absent. If reproducible command following is absent, the examiner should move on to assess the next core behavior. The next core behavior is fixation and visual pursuit. To assess this behavior, the examiner will place a handheld mirror approximately 4 to 6 inches in front of the patient's face and instruct the patient to look at the mirror. The examiner will slowly tilt the mirror 45 degrees to the right and hold the mirror in this position for at least 2 seconds. Then the examiner will repeat this procedure by tilting the mirror to the left of midline and above and below midline, holding the mirror in each position for at least 2 seconds in each location. Each of these directions, above, below, left, or right of midline, counts as a trial that can be scored. This procedure is completed a total of 2 times so that the examiner can score a total of 8 trials. The examiner can score an accurate response for visual pursuit when the patient's eyes follow the mirror for 45 degrees without a loss of fixation on at least 2 occasions in any direction. The examiner can score an accurate response for visual fixation when the patient's eyes change from the initial fixation point and refixate on the new location for at least 2 seconds on at least 2 occasions in any direction. For example, let's say the examiner presents the mirror, but the patient demonstrates no response while the examiner tilts the mirror to the right, left, above, and below midline. As the patient's eyes did not move appropriately in response to the mirror, the examiner should mark a 0 for each of the first 4 trials. The examiner should then present the mirror in each direction a second time. Let's say this time the patient appropriately follows the mirror without a loss of fixation when the mirror is tilted above midline. They do not respond when the mirror is tilted below midline. They appropriately follow the mirror while it is tilted to the right of midline, but they look up when the mirror is tilted to the left of midline. In this example, the patient demonstrated a total of 2 appropriate responses to the visual stimuli, therefore meeting the criteria for fixation or visual pursuit. The examiner should then mark the left-hand column with a 1 to indicate that this behavior is present and may discontinue the assessment. If the patient does not demonstrate at least 2 appropriate responses to the visual stimuli, suggesting that visual fixation or pursuit is absent, the examiner should mark the behavior with a 0 and move on to assess the next core behavior. The next core behavior on the CRSR-FAST is automatic motor response. Automatic motor behaviors are complex, overlearned movement sequences that occur in response to specific environmental triggers and that cannot be attributed to reflexive activity. Some examples of automatic motor behaviors are nose scratching, grasping the bed rail, and picking up objects. There is no specific test procedure to assess for the presence of automatic motor behavior, so the examiner should observe for episodes of automatic motor behavior that occur spontaneously during the examination. Automatic motor behaviors can be scored as present if the patient demonstrates at least 2 different episodes of automatic motor behavior during the assessment. Each episode needs to be clearly differentiated from a reflexive response. For example, if the examiner observes the patient scratch their head once during the exam, and then at a later point during the exam, the patient attempts to pull at their NG tube, then the examiner can mark a plus for each observation and mark a 1 in the left-hand column to indicate that automatic motor behaviors are present. Note that this item can also be credited if the patient demonstrates 2 distinct episodes of the same automatic motor behavior. As the presence of automatic motor behavior is a core sign of consciousness, the examiner can discontinue the assessment. However, if the patient does not demonstrate at least 2 discernible automatic behaviors during the examination, then the examiner should mark the box and column with a 0 and continue the assessment. The next core behavior on the CRSR-FAST is localization to noxious stimulation. To evaluate localization, the examiner should use their thumb and index finger to apply firm pressure to the patient's finger or toe for approximately 5 seconds. This stimulus is intentionally less intense than nail bed pressure or other highly noxious techniques, allowing the patient an opportunity to identify and locate the point of stimulation rather than responding reflexively. Administer at least 2 trials on each side of the body for a total of 4 trials. If the patient's range of motion is restricted, stimulation may be applied to alternative regions such as the chest or thigh. For localization to be considered present, the patient must use their non-stimulated limb to locate and make physical contact with the point of stimulation in at least 2 out of the 4 trials. Localization may also be scored if the patient uses their non-stimulated limb to contact the examiner's hand during administration of the Arousal Facilitation protocol. If observed, attempted localization toward a breathing tube can be scored as present if the movement is specific to the tube and not a generalized posturing response. Even if the patient is prevented from making contact due to safety restrictions, scoring is permitted as long as the attempt is isolated to the stimulated limb and meets these criteria. For example, if the examiner applies pressure to the patient's right finger for 2 trials and the patient reaches with their left hand and makes contact with their right finger on both trials, then the examiner should mark localization with a 1 in the left column to indicate the core behavior as present and discontinue the exam. However, if the patient does not accurately identify the source of stimulation on both trials, then the examiner should administer 2 more trials to the opposite side of the patient's body or apply pressure to a different limb. If the patient does not respond to the additional 2 trials, the examiner should mark a 0 for both trials. If the patient has more than 2 non-responses or inaccurate responses over the 4 trials, then the examiner should mark the left-hand column with a 0 to indicate that localization is absent, and then move on to assess the next core behavior. The last core behavior assessed on the CRSR-FAST is intelligible expression. To administer this portion of the assessment, the examiner should tell the patient that they would like to hear their voice and then administer 2 different verbal prompts. The manual includes 2 examples of open-ended statements designed to prompt the patient to complete the sentence. For example, the first statement begins with, "The opposite of up is." The examiner should provide 10 seconds to allow the patient to respond to the prompt. Each verbal prompt should be administered twice. The patient's verbal response must consist of at least 1 consonant-vowel consonant triad. 2 different words must be documented by the examiner to ensure that a repetitive word-like sound is not mistaken for a word. The words do not need to be appropriate or accurate for the context, but they must be fully intelligible. The patient can also respond by mouthing or writing the word or using an alphabet board if the response otherwise meets the scoring criteria. Verbalizations that occur spontaneously or at other times during the assessment and meet the criteria should also be scored. If the examiner provides a prompt and the patient's response is not intelligible, or the patient responses but the response does not meet the CVC response requirement, the examiner should mark the trial with a dash. If the examiner provides a prompt and the patient does not respond, then the examiner should mark the trial with a 0. If the patient's responses to the verbal prompts are unintelligible, or they do not respond to the prompt, and they have no spontaneous intelligible verbalizations throughout the examination, then the examiner should mark the box in the left-hand column with a 0 to indicate that intelligible expression is absent. If the patient is unable to meet scoring criteria for all core behaviors, then the examiner can conclude that the patient is unconscious. However, if the patient meets scoring criteria for any of the core behaviors, then the examiner can determine that the patient is conscious. Remember that the examiner is not required to assess for all core behavioral signs of consciousness. The presence of a single core behavior is sufficient to determine that the patient is conscious. However, the examiner should always administer items to assess reproducible command following. For patients who are conscious, the examiner may choose to administer supplementary items to assess behaviors suggesting a higher level of cognitive function. Supplementary items include the assessment of functional object use and functional communication. These behaviors, when present, may suggest that the patient has emerged from the minimally conscious state. Specific instructions for administering the supplementary items are summarized on page 6 of the manual. To assess for functional object use, the examiner needs two different common objects, such as a cup and a comb. The examiner should place one of the objects in the patient's hand and instruct the patient to demonstrate how to use the object. Then, the examiner should place the second object in the same hand and restate the instructions. The examiner should repeat the above procedure using the same object so that 2 trials are administered with each object for a total of 4 accessible trials. If the patient is unable to hold the object because of a neuromuscular impairment, then the examiner should note this on the record form, and the item should not be scored. The patient must execute movements that are generally compatible or appropriate for the object's specific function. For example, raising the cup to the mouth or placing a comb near or on the head, on all 4 trials for the examiner to score functional object use as present. If the patient does not respond, or if the patient's movements are incompatible with the object's function on 1 or more trials, then functional object use cannot be scored as present. If the patient demonstrates evidence of command following or spontaneous yes or no responses during the assessment, then the examiner can administer the 6 situational orientation questions from the communication assessment protocol to assess for functional communication. The communication assessment protocol is summarized on page 6 of the manual. The examiner may use the visual set or the auditory set or both sets if appropriate. The patient may provide a verbal response or another form of clearly discernible communicative response, for example, a head nod or thumbs up to the prompt. The patient's response must occur within 10 seconds of the delivery of the prompt to be scored. For the examiner to score functional accurate communication as present, the patient must demonstrate clearly discernible and accurate responses on all 6 of the visual or auditory situational orientation questions from the communication assessment protocol. For the examiner to score non-functional but intentional communication as present, the patient must demonstrate a clearly discernible communicative response. In addition to verbal responses, other communicative responses may include head nods or thumbs up on at least 2 of the 6 situational orientation questions. For non-functional but intentional communication, the responses do not need to be correct to be scored as present. There are a few different options to consider when scoring the CRSR-FAST. Unlike the full-length CRS-R, which is scored as a total score between 0 and 23, the CRS-R-FAST does not generate a single total score. There are 3 distinct approaches to scoring the CRS-R-FAST: a dichotomous rating, a count of conscious behaviors, or diagnostic ratings for classification. Option 1, in its simplest form, the examiner can use a dichotomous rating of consciousness. If any of the 5 core behaviors are scored as present, the subject is considered conscious. If all 5 of the core behaviors are absent, there is no evidence of consciousness on this exam. Option 2, if the examiner elects to assess all items on the CRS-R-FAST, they can report the total number of conscious behaviors present. The minimum is 0 behaviors present. The maximum is 7 behaviors present, which includes both core and supplementary items. Option 3, given that the CRS-R-FAST is designed with stopping rules that allow examiners to abort the assessment if a consciousness behavior is observed, the DOC diagnostic ratings should be used with caution. For example, if command following is observed and the assessment is stopped, the diagnostic rating is at least MCS+. but could also be emerged from MCS, a determination that can be made only if supplementary items were administered. Note that multiple factors could contribute to failing to observe a consciousness behavior. For example, behavioral fluctuation, sedation, and cognitive motor dissociation may mask overt signs of consciousness. Moreover, the CRS-R-FAST includes only a subset of MCS items. Therefore, the absence of behaviors consistent with consciousness is not a definitive indicator of unconsciousness. Multiple examinations are recommended to decrease the probability the signs of consciousness are missed. This brings us to the conclusion of this training on the CRS-R-FAST. Use of the CRS-R-FAST requires appropriate licensing. For detailed information about obtaining a license, please visit the Rehabilitation Outcomes Center at Spalding website. If you have further questions or wish to request permission to use the CRS-R-FAST for clinical or research purposes, please contact us directly. This is the end of the training. Thank you for listening.